Okay, welcome everybody. Hopefully everybody can hear me. I'm going to talk for a few minutes on the cystic ovarian lesions, differentiating things that look bad and things that don't look so bad. And I'm going to talk about ultrasound and MR really quick, because these both kind of go together when it comes to looking at ovarian lesions. And just for some background, there have been guidelines, imaging guidelines, and ways to characterize lesions by imaging for many years, since 2010. And what happened recently is that the SRU folk, which are the people from the US, and the IOTA folk, who are from Europe, came together and made the new O-rads, ultrasound, lexicon, and risk stratification system. But it's really not that new. It's really kind of a combination of those two things. And then on the MR side, the MR at NEXT score has been around, particularly in Europe, since 2013. And those folks got together with a few people who are experts here in the US and developed the O-rads MR risk score. And you see there that ultrasound and MR are very sensitive for ovarian cancer, with MR being slightly more specific. And so here's just here's some background to why that is, or how those numbers came about. And so when we look at lesions on ultrasound, what are we really diagnosing in the end? So this study was done that we did. We looked at like 750 some odd lesions, and we took the IOTA and SRU kind of rules and characterized them as either malignant, benign, or indeterminate. And what happens is when you call something benign using both IOTA and SRU criteria, there's really absolutely no chance of cancer, very, very low, if any. If you call something indeterminate using these criteria, you see that there's somewhere between a 5 and 10% chance of cancer when these lesions eventually get followed up and or taken out. And when you call something malignant, there's a 20 to 30% chance that it turns out to be cancer. And so that's kind of the upshot, is that if you use imaging criteria that are out there, you're going to be really sure something's benign. If you're going to call something indeterminate by these criteria, there's a small chance of cancer, but pretty significant, and that's, I think, where MR can be helpful. And then if you call something malignant, there's a very high chance, or a higher chance of cancer. And again, in this category, a lot of these patients will probably go to gynonc, but some will end up maybe with an MR if they're younger, because not all things you call malignant turn out to be malignant on ultrasound. That's just the reality. So here's just an example of what I mean. So these are 3 cases we had, and they all kind of look like dermoids. And so in your mind, which ones do you think are dermoids? Just kind of like pick 1 or 2 cases, or you think all 3 of them, that's fine. And then I'll show you the MR. So case 1, MR. Here's the coronal T2, this is the uterus, here's the lesion. Here's the post-contrast, here's the uterus, here's the lesion. Case 2, here is the lesion where the arrow is, here's the uterus. Here's the post-con, uterus, lesion. Last case, here's the axial T1 without and with fat sat. Nothing enhanced post-contrast. So out of these 3 cases, which all sort of look like dermoids, there was a fibroma, a borderline Brenner tumor, and a dermoid. So this is kind of one of the teaching points to take away, is that ultrasound is very good at characterizing benign lesions and certain very characteristic lesions. But even if you're not sure, it's not classic slam dunk dermoid, which I think none of these on ultrasound really are. I mean, there's areas of shadowing. There is maybe some DOSH-DAT here, but not really. These are the hard cases, and these are the ones that I think MR really benefit from. One other case, or one other instance I think MR is very helpful, is when you have big lesions, or lesions that maybe are incompletely evaluated on ultrasound. And so here's a case, she's 42, called a simple cyst, probably not worrisome, but then went to MR, and there's this enhancing nodule that's got kind of a snowflake appearance or papillations to it, and it's kind of covered up by this reverb artifact here, so totally missed on ultrasound. And so this was a borderline tumor. So those are the cases. I don't want to get into all the details of O-rads. I just want to make sure you are aware that they're out there, and the lexicon is coordinated between ultrasound and MR and is really simple, actually. The terminology has been developed to try and make it homogeneous between the two imaging modalities and to keep it simple. And so terminology that is being used in the lexicon is physiologic, so follicle corpus luteum. If it's not a physiologic finding, it's a lesion. So the lesions are called unilocular, multilocular, or solid. And then you can describe them, the fluid and the solid parts, by the descriptors you see there, plus or minus blood flow / enhancement. So here in your mind, these are the descriptors. The images correlate to which of these descriptors. I'll give you like 30 seconds to make up your mind here. So simple fluid, hemorrhagic fluid, endometriotic fluid, and proteinaceous fluid. Similar on MR, you've got more images to look at, but you've got the same descriptors. And so which ones are which here? I'll give you 35 seconds for the MR. All right, so simple fluid, dark on T1, bright on T2. Hemorrhagic fluid tends to be bright on both T1, T2. Endometriotic is bright on T1, very dark on T2, or gray on T2, or shaded, however you want to say it. Proteinaceous is variable, and so when it doesn't fit these two, then you call it proteinaceous. Proteinaceous can include some hemorrhage in it, depending on the age of the hemorrhage. When hemorrhage gets to be in the subacute later phases, which is a pretty long, couple weeks period there, it is bright and bright. And then as it gets older, it gets dark on the T2. So in the first 2 weeks, it can be variable and be mistaken for proteinaceous fluid. But time will give you probably the best benefit in figuring out which is which, proteinaceous versus hemorrhage. Plus, if there's multiple locules like this, it's probably not a hemorrhagic cyst. It's probably a mucinous lesion. And then lipid can be liquefied, and so sometimes you see it fat out on the fat image or lose signal on the in-phase, out of phase when you're looking at the in-phase, out of phase. All right, solid components. Here are the 4 descriptors for that. I'll give you a few seconds to look and decide which are which. So here's pretty little papillary projections. This is a mostly solid mass, so if it's greater than 80% solid, you can call it a solid mass. Irregular septations are septations that have irregularity to them or uneven contours. And nodules look like round things that are coming off of the wall or of a septation. Similarly, on MR, you've got nodules, you've got papillary projections. Now, papillary projections on MR are usually quite beautiful. They kind of look like snowflakes or pieces of broccoli or vegetations of other kinds, whatever kind you like. Irregular septations, similar to ultrasound, are just going to be irregular, uneven in contour, and solid masses, similarly, greater than 80% solid, you can call it a solid mass. Things that are solid appearing but are not actually worrisome, like soft tissue, what I've just shown you is worrisome. There's a few things that are kind of solid appearing but not worrisome. On ultrasound, it's fat and clot. And here's some examples of fat and clot. And similarly on MR, clot and debris doesn't enhance. Smooth, thin septations are not worrisome, and fat's not worrisome. Blood flow is important. No blood flow is good. Lots of blood flow is bad. Enhancement that is less than or equal to the myometrium is better than enhancement that is more than the myometrium. Some people do dynamic perfusion curves, and these are very actually specific, and so high-risk curves have a greater than 95% positive predictive value for cancer. So I'm showing you a high-grade papillary serous carcinoma here. Here's an intermediate curve, and this lesion is a borderline tumor, and this is a fibroma up top. It's a benign lesion. So if you go to the website, you'll see there are there's an ultrasound and an MR area, and on ultrasound, you'll have the lexicon descriptors and the risk table. And I have sent this to everybody, and if you don't have it, please email me. I'm happy to send it again. But I'm going to quickly just go through this to try to simplify it a little bit, because I think it is a little overwhelming when you look at it. So O-rads 1 is normal physiologic things like follicles and corpus luteal cysts. And the follicles define simple cysts less than 3 centimeters in a premenopausal woman. And then if you don't have one of those things, but you have a simple cyst that's a little bigger, or any of the classic benign lesions that are described as classic hemorrhagic cyst endometriomas or dermoids, you can call that O-rads 2. O-rads 3 are your simple cysts and classic benign lesions that are greater than 10 centimeters, any multiloculated cyst that has smooth septations, and any solid lesion that's very smooth on the outside and has no flow. O-rads 4, you start to get more complex. There's more soft tissue. There's a little bit of flow going on now. And O-rads 5, even more soft tissue and more flow, or you see ascites, peritoneal thickening, or nodularity. So classic lesions, simple cysts, hemorrhagic cyst, dermoid, endometrioma, less than 10 centimeters, O-rads 2. If a classic lesion is greater than 10 centimeters, multilocular cyst with thin septations, smooth on the outside, solid lesion, no flow, O-rads 3. Multilocular cyst that is greater than 10 centimeters, you've got a little bit of soft tissue going on, but not a lot of blood flow, O-rads 4. Lots of blood flow, septations with flow in them, lots of soft tissue, O-rads 5. And so here you go. Benign, classic lesions, O-rads 2. Bigger, benign lesions, greater than 10 centimeters, O-rads 3. Multiseptated thin septations or solid lesion that's smooth on the outside. Everything else is a 4 or 5. And I'm kind of clumping these together to simplify. Basically anything that has irregular septations or septations with lots of flow or solid tissue within it is O-rads 5. All right, I just have a couple cases. I know we're going to show cases after this, so I won't belabor this, but in your mind, we're just going to go over a couple and then we'll go into MR. So here are 2 cases, and basically, what do you think these are? And then on the next slide, I'll show you what they are. So these are both O-rads 2 lesions. This is a simple cyst, less than 10 centimeters. This is an endometrioma, less than 10 centimeters. What about these 2? O-rads 3, multilocular cyst with smooth septation, dermoid 2. Okay, let's skip this one. How about this one? All right, this is going to be a 4 or 5 because you've got some irregular soft tissue in there, plus or minus blood flow. This is a dermoid, but it's huge, so it goes into O-rads 3, so just remember that. Last set of cases here. We're starting into the things that have like soft tissue to them, plus or minus blood flow, and so O-rads 4 or 5. Okay, MR. Similarly, you could go to the website, there'll be an MR tab, and then you can pull up the risk stratification system. I'm going to simplify it again. Similar to ultrasound, O-rads 1, physiologic lesions. O-rads 2, all your classic lesions, no size criteria. The only thing added on the MR side is if you see a homogeneously dark T2, dark high DWI image, soft tissue lesion, that is a benign lesion. So you can call it benign. And the risk of cancer is less than 0.5% in this category. O-rads 3, similar multilocular cyst that doesn't have any regularity, any regular soft tissue or no soft tissue to it. If you're doing a dynamic run and you can say that that soft tissue that you see in a lesion has a low risk enhancement curve, then you can call it a O-rads 3. A lot of us are not doing this, so you can kind of forget about this. So basically all you have in O-rads 3 is multilocular cyst with no soft tissue. Soft tissue is defined as things that enhance that look like papillary projections, soft tissue nodules, irregular septations, or other solid components. O-rads 4 has dermoids in there that have a large amount of soft tissue because occasionally dermoids do degenerate to squamous cell or carcinoid or something else. And those usually, what you see is you see the dermoid and then there's all this soft tissue in the wall. Occasionally dermoids have a little soft tissue in the center that has fat in the soft tissue, and that's a dermoid plug or a Rokitansky nodule. That's okay. But when you start seeing big soft tissue goombas in the wall or along a septation more than what looks like a Rokitansky nodule, that's what you stick in O-rads 4. And then you also, if you have a cyst or a solid lesion that has an intermediate risk enhancement curve or is enhancing less than or equal to the myometrium, you put it in 4. And if it's enhancing greater than the myometrium or has a high risk curve, then it's a 5. And the peritoneal thickening and nodularity is a 5. So simple cysts, hemorrhagic cysts, just examples here. Endometriomas, dermoids, regardless of size, O-rads 2. Homogeneously dark lesion, dark on the high B value, dark lesion, O-rads 2, not cancer. O-rads 3 lesions are if you have a dermoid with, oh, forget this slide. Nobody saw that. I forgot to take that out of there. So multilocular cysts, thin septations, no soft tissue. O-rads 4 is dermoid with a lot of soft tissue that's in the wall. O-rads 4, lots of soft tissue or some soft tissue enhancing less than or equal to the myometrium. O-rads 5, soft tissue, and it could just be a small amount of the tumor that's enhancing greater than the myometrium. Here's another lesion. Part of it is enhancing more than the myometrium. Okay, so benign, classic lesions, and your dark lesion. O-rads 2 is multilocular cyst basically, and everything else. Anytime you see enhancing soft tissue that looks like a papillary projection or a nodule or lots of soft tissue, that's O-rads 4 or 5. All right. I know I'm over, but just a couple cases. Is that okay, Artie? Probably. Okay. So these were both okay, O-rads 2. Okay. O-rads 2, we're going to do the same thing here. So what about these? Okay. This is high on T1, high on T2, no enhancement, totally benign, no chance of cancer, or very little. This is fat satted out, no enhancement, dermoid, benign. So dark on T2, dark on the high B value. Who cares how it enhances? It's dark, homogeneously, O-rads 2. Gray gets bright on the high B value. It's not dark, and it enhances, and it kind of looks irregular. O-rads 4 or 5. So fat sats out, little Rokitansky nodule right in the center here. This is very classic for what these look like. O-rads 2. Gray soft tissue gets bright on the high B value, enhances. O-rads 4 or 5. Okay, that's it for me. Liz, this is acute adenofibroma.
That was awesome. We have some questions. So
sure.
first question is, how does management change with O-rads?
So the ultrasound O-rads management is given on their site, and you can go look at it, and I can pull it up. But basically, it falls in line for the most part with the SRU guidelines. So there's a little bit of a difference, but not a huge amount of difference. And I think the difference between 4 and 5, so if you have a 2 and it's benign, you're either gonna follow it because, I don't know, it's a little on the big side, or you're gonna completely ignore it. And I think that's kind of the, when you go there, you'll see that's very similar to SRU. O-rads 3, you're gonna follow an O-rads 3, but the way you follow it may depend on your local gynecological colleagues. And like here at the UW, we send most of those patients to MR. Other places will follow with ultrasound. So there's a little variability there. And again, that's kind of based on your local gynecological colleagues many times. O-rads 4 and 5, in the 4 category, a lot of those lesions will also get followed or sent to gyn-onc. So you have the option in O-rads 4 to either follow it with MR or send it to gyn-onc. So that's, again, totally dependent on your gynecological colleagues. So there's this element of, yeah, you need to reach out and figure out what the gynecologists want with some of these lesions. And O-rads 5, if you're going to diagnose something O-rads 5, those people pretty much all go to gyn-onc. On the MR side, we actually did not come up with management guidelines because we decided that the positive predictive value for cancer is really what we're confident in. And in regards to managing these patients, I think that the gynecologists, by that time, hopefully they're seeing a gynecologist, particularly if you have an O-rads 3, 4, or 5 lesion, or a gyne-oncologist. And so that information will be taken into context with their clinical picture, because I think if you have, say, for example, an O-rads 3 lesion, which is not super worrisome, but you know that she has, she's young and she has a beta HCG or some other marker, tumor marker for, you know, malignant teratomas, you're going to have to manage it that way. So I think that's why we stayed away from management. So that's a really long answer to that, but I would be happy to continue the discussion offline for anybody who's more interested in talking about this.
Related to that, do you think like O-rads 5 lesions on ultrasound need an MR, or they can go straight to the operating room?
So at our institution, our data, which I showed you at the very beginning, there's only about 30% of malignant lesions that are called on ultrasound that actually end up being malignant. So what we do here is we actually look at the clinical scenario and we give the referring physician the option of the MR if more clinical information is needed versus sending to gynecological oncology. So if they're coming from a primary doctor or a gynecologist, we basically put in our note that depending on the clinical scenario, if further characterization is necessary, MR could be considered. However, gynecological oncology consult is recommended. So we kind of give them the option of both at the moment. That's how we do it. I think, again, you're going to have to just decide with the gynecologist at your institution, what do they want to do about these lesions?
Okay, a couple more questions. At the beginning, you mentioned that there was the SRU guidelines in 2010, and then O-rads came in 2020. There was also a recent SRU guideline, correct? And when, I mean, I guess, what do you, like, one of my friends, for example, asked me, like, do you use O-rads or do you use SRU? And I guess, what would you, like, kind of, it sounds like you're championing O-rads, but what do you do for people who are still using SRU, or what do you think about the other SRU guidelines?
Yeah, so the SRU guidelines, I think were updated in terms of management. So like you didn't have to do something about certain lesions and a little more specific. I mean, I think to each his own. You want to use SRU still, that's fine. If you want to try O-rads, that's great. I'm on the O-rads MR committee, not the ultrasound committee, but I'm part of the group. And, you know, I think that the lexicon is the biggest thing. Like, it would be great if everybody could begin to use the same words. That's my opinion. In terms of the risk score, I think you need to use what you're comfortable with and what your treating physicians want you to use.
Awesome. Okay, one last question, which is the role of serum CA-125 for ovarian masses. Do you use that, and how specific is it?
So if it's elevated, it helps you out because you know that there's something going on. If it's not elevated, it doesn't really help you out because borderline tumors and early ovarian cancer, stage 1, and sometimes even stage 2, have very low or kind of normal beta-8 CGs. I'm sorry, CA-125. So that's the only word of caution, is just because you don't have an elevated CA-125 doesn't mean you're not looking at a borderline tumor, a low-grade tumor, or a stage 1, stage 2 high-grade papillary.
Yeah, and some other cancers also can have it elevated, I think, such as, oh, and somebody else wrote in pathology such as PID, TB, and endometriosis can show a rise in levels, and then also certain GI malignancies can also raise it. So it's not just for ovarian cancer.
Yep.
Okay, awesome. I'm going to stop the recording.